Hello, my dear doctors. How are you all? Hoping all are doing well and well practice, and some candidates exam very near. So today my last session. I hope all enjoy my course also. And my strong advice always, as we are doctor, we have to keep practice always, and we have to be updated regarding whatever the field and whichever the situation accordingly. Even nowadays, very high internet connection and there is a high updated topics, we can update ourselves. Though some candidates are postgraduated or postgraduate course, so we can update our knowledge. Because though something against our we license that what I face that they don't follow according to the guideline. That is the fact. Sometimes we have to face some difficulty during the examination time or during the exam time, and during when we have to mark the exact question, we are feeling that this is the answer, but somehow they don't follow those rules or guidelines. So we have to do first. This is my first target. So for doing first, we have to follow their marking what they mark correctly. That is why I am conducting this course that for correction for passing the exam in first attempt. So today, Ghanaian obsession regarding the labor and the CTG interpretation. It is still didn't I touch, but thing is that CTG interpretation. Okay, they may ask or they'll give the images, and I strongly suggest for CTG interpretation in ALA note 4 to 5 images in CTG. Just remember variable deceleration, early late deceleration, and the example percentage sufficiency, magnesium sulfate toxicity. That's it. And even the scenario when you face in the exam, you can understand it is the answer. Okay, because they will not confuse you, and the figure and images clean cut scenario. So today, first of all, I want to little bit brief regarding the diabetes mellitus and gestational diabetes. So see, second and third trimester, we have to see the HbA1c. So see, you can ask me why, ma'am, in second. Actually, in second and third trimester, glucose intolerance higher because there is a gestation, there is hormonal imbalance, so it increases. So HbA1c less than 6% has the lowest risk of large or gestational age infants. So if HbA1c below 6%, so there is a lower risk for having complication. Importantly, because of the associated elevated glucose value, it entails abnormality, congenital abnormality. So gestational diabetes mellitus entails congenital abnormality. So in congenital malformation, we have to confirm the glucose level lowering, and it impaired or it impact on the organogenesis. So it is very important to decrease glucose level. So today I'll discuss more question, though it's a very easy and direct question, but these are the clinical scenario for the exam. So first question will be discussed with me, Dr. Donilda. First question.
Yes, ma'am. Patient with a long history of diabetes type 1 in 12 weeks of gestation, H1B, H1A1C 12, which of the following complication most likely to happen? Preeclampsia, polyhydramnios, congenital malformation, IUGR. I think it's D, IUGR.
So Dr. Donilda already I discussed one topic that we have to keep below 6% HbA1c, right? And
Hmm.
she is 12 weeks, and the first you can see is the second trimester starting. It's not completing, but second trimester starting. You can see.
Hmm.
So in this case, HbA1c 12 means is a high risk for organogenesis. You see, already there is a description that you don't need. You see, there is a high risk for fetal anomalies. Fetal
Okay.
anomalies,
Congenital
organogenesis will
malformation.
be impaired. The
Huh,
answer
congenital.
is Dr. Donilla clean
Congenital.
cut. You can say, yeah.
Congenital. Yeah,
If Dr.
malformation.
Donilla same question, if there is a higher blood pressure, high gestational hypertension, answer will be what? Answer will be IUGR.
IUGR. IUGR.
Okay.
Okay.
Okay. IUGR.
Yeah, yeah.
Okay. Thank you, Dr.
Thank you.
Donilla. Second
Thank you.
question. Second question, clinical scenario
তিনটায়
for the
গেল
DHA, Dr. Yeah, Dr. Donilda. Okay. Second question by Dr. Is Reza.
Hi, ma'am.
Yes.
Patient diabetic and pregnant. What's the most useful test that will determine prognosis for the baby? OGTT, fasting blood glucose, glycosylated hemoglobin, US local translucency. Diabetic, then determine prognosis. Fasting blood glucose not be exclude OGT just for diagnosis of diabetic of pregnant mother exclude glycosylated hemoglobin and US local translucency. Option D shows any abnormality in the fetus, and glycosylated hemoglobin shows I think prognostic factor may be option C and option D, but glycosylated hemoglobin shows the history of glucose in the mother and the control of the glucose in the mother. It's a prognostic factor, but for fetus, I think the option D is better.
Option?
D.
Okay. So your analysis interpretation good, Dr. Reza, I'm appreciating. But the thing is that see,
C. Okay.
ultrasound. Okay. No, let's
Yes.
see. I'm telling ultrasound knuckle translucency doesn't determine prognosis. No, only sugar is my life-threatening part. Either my baby will be develop
Yes.
organogenesis abnormality or no. So I have to keep strongly sugar and blood pressure.
Yes.
Those are the part for the high demand for the exam question. No one can do any wrong. Both topics I discussed already. So now to the diabetes mellitus, Dr. Reza, your interpretation excellent, C or D. But the thing
Thank
is
you.
ultrasound, we will do ultrasound yes 2 weekly. In second trimester, weekly according to the presentation. But to see the fetal distress, fetal movement, but always we have to check glycosylated hemoglobin as our target below 6. But if it is high, like Dr. Donilda's case, HB1C 12, so it increase risk for organo fetal anomaly or embryogenesis congenital anomaly or organo malformation or organogenesis, whatever you say. So the thing is that we have to understand the determined prognosis for the baby is the glycosylated hemoglobin. Clear, Doctor?
Yes. Okay.
Clinical scenario, even you can see same question in the exam. But the thing is that no need to so much brain working. Just clinical scenario I have to mark. Honestly, this is the glycosylated hemoglobin level. Clear, Doctor?
Yes. Thank you.
Okay, thank you. Third question will be discussed with me. I will discuss today more question. All are the exam collection. Dr. Saba. Third question for Dr. Saba is not here, so Dr. Ikra.
Assalamualaikum, ma'am.
Alaikum salam.
Ma'am, actually, question is not appear on my screen.
Now,
Yes. Female hypertensive and diabetic. Ma'am, this one, na?
yeah, female hypertensive and diabetic, yes.
Female hypertensive and diabetic on ACI and insulin, metformin. She decided to get pregnant soon. Labs heavy proteinuria HbA1c 8. What's your most appropriate advice for her regarding diabetic control and fetal congenital malformations? Stop snacks and start 3 heavy meals a day. Switch ACIs to ARBs. tried to control her HbA1c to normal or near normal as possible before pregnancy. Increase the dose of ACIs. Ma'am, it's option C. Try to
Mhm.
control her HbA1c to normal or near normal as possible before pregnancy.
Excellent. Excellent, Dr. Ikra. Why? Because HbA1c8 already started proteinuria. We will keep AC inhibitor for renal pressure, but now we can't keep AC inhibitor.
Yes,
It causes
teratogenic.
teratogenic effect. So we have to improve HbA1c level before
Yes,
pregnancy. Okay, thank you,
yes.
Doctor.
Yes, ma'am. Thank you, ma'am.
So third question, mother came for antenatal care. This question will be discussed with me. Dr. Monia Jaman is here. Okay, Dr. Shruti.
Yes, ma'am. Uh, Mother came for
Yes.
antenatal care and ultrasound shows week 32 reversed diastolic blood flow. Follow up 2 week and reassess. Immediate delivery now. Administer steroid 1 week and delivery. NST. And is it NST?
Non, it's the NST means what? It's a
Non-stress test.
non-stress test. But see, one life-threatening option here, you see, non-stress test we see for fetal heart rate, fetal condition, right?
Yes, ma'am. Yes,
So thing is that this is 32 weeks, but reversed
ma'am.
diastolic blood flow. What is that? Can she continue the pregnancy or not?
No, ma'am. No, ma'am.
No. So what is the answer?
Okay. Administer steroids 1 week and immediate delivery now.
Immediate delivery now. We
Oh,
can't do wait. We
okay,
can't do wait. Okay.
okay, ma'am.
So
Okay.
immediate delivery
Delivery
now.
now.
I'll explain details after third question explanation. Thank you, Dr. Shruti. I'll discuss this
Okay,
topic today.
okay.
This topic is all details I will discuss later. Third question by Dr. Badhon. Easy
Morning,
question.
ma'am.
Walaikum salam.
Pregnant lady on 30 weeks on antenatal care. On ultrasonography finding, fetus size decreased than before with oligohydramnios. Doppler of umbilical artery find reversed diastolic flow. Mother denied any loss of fetus movement. What is the appropriate next step? Non-stress test, serial ultrasonography after 1 week, serial Doppler for umbilical artery after 2 weeks, and thick fetal chart. Okay. It's a life-threatening condition. 30 weeks, pregnant lady, and fetus size decrease, oligohydramnios. Doppler, any loss of mother denied any loss of fetus movement. Okay. Then here in ratio of mother and fetus risk, I will check for mother. So I can, what is the appropriate next step?
So I'm giving
Um,
instruction. It's a 30 weeks, right? In natal
yes,
care,
ma'am.
this patient come to your hospital. 30-week pregnant lady come to your hospital in natal care checkup, and you done ultrasound which reveal that fetus size decreased than before with oligohydramnios. So there is oligohydramnios and fetus size became
Yes,
decreased.
ma'am.
Okay.
IUGF.
Doppler of umbilical artery find. So see what is that? First question, Dr. Shruti's question that 32 weeks in diastolic blood flow reverse. See, it is a life-threatening issue. Your case,
Yes.
30 weeks. Doppler umbilical artery same showed reverse diastolic flow mother denied any loss of fetus. So you done and it revealed reverse. I'll discuss. So this reverse diastolic flow is a lab threatening for the mom.
Yes.
Okay. So in this condition, mother denied any loss of fetus movement, and you are asking, and mom said there's no loss of fetal movement. So you are a doctor. Mom telling I don't have any loss of fetal movement, but you have to check what? Fetal
Non-stress
activity,
test.
fetal cardiac. The answer is non-stress
Non-stress.
test. Okay. Thank you, doctor. Thank you. You
Thank
tried
you.
your best. Yeah. So today this reversed. Today I'll discuss regarding this reversed diastolic flow. This is the what, okay, because we have to remember just directly what they are, how we have to do answer. So fetal growth restriction if abdominal circumference below 10th or maternal hypertension present. So there is a, we have to do weekly. Hello, kindly mute the mic, kindly mute the mic, don't unmute because this is a very important session ongoing. First of all, fetal growth restriction, Dr. Badhun case, you already the 30-week, but you done ultrasound which revealed the fetal size decrease by oligohydral, same Dr. Badhan's case. So in this case, weekly we have to do ultrasound Doppler, biophysical profile, and non-stress test. Okay, so it's a reverse diastolic volume, it's a absent diastolic volume, and there's a reassuring test result. 3. We done Doppler ultrasound, we done non-stress test. It could be 3, that urinalysis reversed diastolic volume or absent diastolic volume. So we have to take accordingly the decision. If reverse, our question, our exam part, just you see this part is our exam part. Reverse in diastolic volume if it is more than 32 week, Dr. Shruti's case, we have to do deliver right now. Dr. Badhun case was 30 week. If it is not 32 weeks, we have to do non-stress test or biophysical profile and weekly Doppler. So Dr. Badhun case, we have to do non-stress test. Gestational age when it will be the 32 week, okay, or it is non-reassuring because we have to do this biophysical profile, non-stress test, but it is not reassuring. We can't reassure that the mom can continue the pregnancy or not. So we have to do deliver. So these are the exam part. Absent in diastolic volume more than 34 weeks, we have to do delivered. If no, we have to do again same non-stress test, then delivered. But exam reverse industrial common DHA exam question, common paid question. They don't ask regarding the absent industrial volume. They don't ask regarding the reassuring. They don't ask whether they were the other the abdominal circumference below 10 centimeters. So they ask reverse. So reverse, remember only one point. You can take a note that if below 32 weeks, we have to do non-stress test. If it is already 32 weeks, equal or more than 32 weeks, we have to do delivery right now. Non-stress test we do to check baby's health, baby's heart rate monitoring, whether baby's movement, we have to do reassure and we have to do confirm that baby's movement, what about that? But after 32 weeks, if baby deliver normally, though chance is low, but reverse diastolic volume, which ongoing mother self, it is very risk for life-threatening heart failure or sudden immature labor. So we can't continue this value, just one confirmation. If we do deliver the baby, the NICU support can carry and it will be normally we can carry this baby's health. But the thing is that we have to confirm mom and baby's full pregnancy. First question will be discussed with me, Dr. Moshumi. First case. Question 1. Don't do
Yes,
mismatch. Question
ye-
1. Okay.
yes, ma'am.
Yeah.
Pregnant who has the child with Down syndrome. She concerned about having another child with Down syndrome. What is the best test to rule out Down syndrome in the second trimester? Amniotic fluid sample, chorionic villus sample, triple test. Amniotic fluid sample, ma'am.
You are explaining for amniotic fluid sample. Can you explain why? First of all, dear, you read that there is a Down syndrome, right? Who has a child with Down syndrome? That it basically the first time, first gravida or second gravida, whatever the thing, that a mom's concern regarding the another child Down. Okay. So what is the best test to rule out? So we have to do what? We have to
Triple.
do no. We have to do chronio-relay sampling to proceed to first trimester. We have to do actually this first trimester. We have to do chronic relay sampling in 10 to 13 weeks. Amniocentesis is the procedure to choice in second trimester. But they said actually amniotic fluid sampling you can do second trimester when already this scenario if they said that is already pregnant, but you see there's a pregnant already mom comes to your hospital but they didn't give the gestation. If it is second trimester we can do amniotic fluid sampling, but first trimester we do chronic villus sampling test. Okay, clear?
Clear, ma'am.
Second question will be, Dr. Saba is not here today, right?
Am I correct?
Yeah, Dr. Saba, I am searching for you. This
Assalamualaikum.
one. Walaikum salam.
Yes. Which question, ma'am?
Second one, dear. This one.
Okay. Question second, 46 years old, gravida 3 para 1 at 34 weeks gestation, presented to antenatal clinic for regular checkup. She has unremarkable medical history and uncomplicated pregnancy. Braxton Hicks and non-pruritic cervical discharge. Her pre-pregnancy weight was 54.4 on examination. Cervical length was 33 mm. Uh, uh, VS were given and I believe there were normal current weight 52. Rubella AB negative, HB SAG negative, blood type O positive. Which of the following is most appropriate next step? A. F, FU after 2 weeks. B. OGTT test. C. Do rubella AB test. Repeat rubella screen. And D. Given anti-DAB. Ma'am, patient is on 34 weeks of gestation and present for the antenatal checkup. And his previous history is unremarkable. Brixton Hicks and non-pruritic cervical discharge. Her pre-pregnancy weight was 54 on examination. Cervical length was 33. So, ma'am, it may be option A.
Yeah, excellent. Why A? Dear, you done excellent. Why A?
OGTT is not, ma'am, OGTT is not need for because there is no history of diabetes and rubella is
Yeah,
negative, so no need for rubella testing again. And given
yeah,
entity is not need because
yeah.
blood type is O positive. So remaining will be option A. So I choose the option A
Yeah,
according to
yeah, by
experience.
excluding method. Excellent, right? Excluding method,
Yes.
right? Yes. Same question, exam question. Actually, this is exam. Actually, MO is recall. That's why I was searching for you. So let's see if we don't have any idea. Let's see the scenario is not as we can understand. It's really the haphazard scenario. I feel so. But the thing is that if we do excluding method, some scenario will be like that in MOH exam question. If you just follow the excluding method, you will mark correctly. Okay. Thank you, Dr. Saba.
Yes,
You done
thank
excellent.
you. Thank you.
Yeah, thank you, dear. So third question, DHA question, very excellent. Even is my exam question. So third question, it's a Dr. Rehana is here. Dr. Rehana.
Yes, ma'am.
Yeah, third question.
A placenta is implanted in the uterine wall. What is that? Placenta increta.
Yeah, excellent. It's the because implanted in the uterine well, right?
Yes, ma'am.
That is the cause. Yeah. Thank you, Dr. Rehana. You done well. Yeah. So third question is done already, and it's a fourth question will be done by. So fourth question by Dr. Hira.
Yes, ma'am. Assalamu alaikum.
Alaikum salam.
36 years old, gravida 4, para 3, 0 abortions, 38 weeks. A case of polyhydramnios. She did ARM followed by vaginal bleeding, and CTG showed fetal bradycardia. What is the possible cause? Abruptio placenta, placenta previa, vasa previa. Ma'am, in abruptio placenta, there should be pain abdomen. It's a
But there
there
is
is no
no. But it is
no
no.
pain.
Okay, and there is a vaginal bleeding, but you see there is a bradycardia also.
Yes, ma'am.
There is
Then
another point is bradycardia. So the vaginal bleeding along with bradycardia. Do you remember
can
CTG?
yes, ma'am. Yes, ma'am. Rupture placenta was there. That if there is fetal bradycardia, the option and CT shows if fetal bradycardia, that will be abruptio placenta.
No. I'm giving clue. First of
Hmm.
all, whatever the exam scenario, I'm telling shortly. You can understand.
Yes, ma'am. Yes, ma'am.
Always for abruptio, they'll give pain. Other than pain, other than what? Tenderness, you will not mark abruptio. No.
Mm.
Okay.
Yeah.
So it's excluded.
Mm.
Now I'm
Yes,
coming
ma'am.
to your point, either B or C. So
Yes,
regarding the
ma'am.
B, previa didn't show this bradycardia.
Yes, ma'am.
Okay.
Yes,
So
ma'am.
the
This is vasa previa.
yes, the vasa previa.
The
Because
previa.
pain
Yes, ma'am.
even it's the in CTG, its name is
Mm.
sinusoidal pattern.
Yes, ma'am.
Bradycardia.
Yes, ma'am.
Okay.
Yes, ma'am.
So it's a
Yes,
so see,
vasa
you are
previa.
confused by B or C. So B could be the answer, but why not B? Because there is a bradycardia. So bradycardia ongoing is a vasa previa. Okay. Also it's a MOH question. Okay, clear? Okay. Now explanation I'll discuss shortly regarding Dr. Mousumi's case that chronic village sampling will do in first trimester, in second trimester amniocentesis or amniotic fluid examination can do. Regarding the Dr. Saba's case, we have to do wait for 2 weeks. Okay, traditional schedule at 4 week interval until 28 week, but every 2 week we'll do until 36 week and weekly. The thing is that till 28 week we can do prenatal visit for weekly till 28, but after 28 week we will do in prenatal visit for 2 weeks. Okay, so twins, a patient have twins or diabetes, we have to do follow up weekly or 2 weekly interval. This is the point. Dr. Rehana's case placenta increta most higher topics for the DXA. They ask direct question. Okay, my exam question was the increta. So see, accreta chronic villi attached to the myometrium, increta villi invade to the myometrium. So when accreta is chronic villi attached to the myometrium and increta along with the wall of the myometrium. Okay, so in the pancreata, penetrates through the myometrium and penetrates through the serosa. So till serosa, if I say serosa, mucosa, submucosa. So Till serosa is a pancreata or parcreata, and increta if it is attached to the uterine wall, or accreta just attached. It's still not inverse. Okay. Vasa previa Dr. Hira's case, just one point twisting is that painless vaginal bleeding actually, if you ask, I will mark previa, but no, it's not previa when they give the bradycardia option. Fetal bradycardia along with sinusoidal pattern only for the vasa previa. Okay, so we have to understand this way what they are telling. My question, three question. At one was the increta, second was the vasa previa, and another was the placenta previa. So two question was the painless, but the thing is that bradycardia was excluded by vasa previa. So we have to understand that abruptio they must give whatever the pain, even in mild pain, which will be the abruptio. Either it's vasa previa or placenta previa. So antepartum hemorrhage, very important exam topics. Vaginal bleeding of gestation that is unrelated to labor and delivery. Interpartum associated with course of normal delivery or normal labor. So third trimester, okay, third trimester there is a three question. Before that, I'll somehow I'm telling seeing there is some interpretation, so don't no need to be worried. I'll read those option A, B, C, D. When I'll post later, it will be more clear. So first question will be discussed with me. Okay, first question I want to discuss same way that it will be more clear for Dr. Hira. Dr. Hira, then she can isolate what is the previous total is. Dr. Hira is not here. I'm seeing she is on line. Dr. Hira is here or not? If Dr. Hira is not here, first question by Dr. Monia Jaman is here. Okay.
Hello, ma'am.
Yeah, Dr. Okay, Dr.
Yeah, I'm
Hira,
here.
I want to
Yeah.
I want to discuss
Ma'am,
first
my
question.
internet was not working, disconnected.
Okay, so will you able to talk with me, or I can choose another candidate?
No, ma'am, I will talk to you.
Okay.
Which question, ma'am?
First question you means that there's a no pain. There's a no pain, but this question you will discuss with the first question that, and you have to discuss where and what is the point for your answer. So this first one.
Third
This one.
trimester pregnant woman? This one?
Yes. Yeah.
Third
There's the
trimester
answer
pregnant.
A, B, C. Yeah. C,
Third
there's a placenta previa, vasa previa, and
yeah.
abruptio.
Yeah. Third trimester pregnant woman with vaginal bleeding, abdominal exam shows a length less than gestational age. CTG shows late decelerations. Diagnosis: placenta previa, vasa previa, placental abruption. Ma'am, late decelerations is placental abruption.
Excellent. So see, there is no pain there.
Yes, ma'am.
Only late deceleration, like your first case. Vasa previa only for the bradycardia. Here, late deceleration only for the abruptio. These are the hallmark sign we have to understand. That's why I'm searching that. You have to understand that there's no pain, but late deceleration sign. So it's a abruptio placenta. Thank you, doctor. So second question will be discussed with me, Dr. Mavis. Second question, this one. If Dr. Mavis is not here.
Yes, ma'am.
Okay. Yeah, this one.
Pregnant in 27 gestational age, came with a minimal bleeding. Ultrasound showed placenta totalis. What is the most important management? 27 weeks of gestation age.
Minimal minimal bleeding. See, there is a minimal bleeding.
Minimal bleeding ultrasound show. Ma'am, steroids?
Steroid. Excellent. How you know this steroid answer? Cause 27, right?
27, yes, ma'am, 27 week, and they didn't give any history of abdominal contraction, so no role of tocolytics or rupture of
No,
membrane. So
antibiotic. So it's not prone. We
antibiotic.
have to start steroid to pre-nurture the lung,
Yes,
right?
ma'am.
To
Yes, ma'am.
improve lung function. Even in mild bleeding, we can give steroid to improve, to decrease the bleeding tendency. Thank you, doctor. Thank you.
Thank you, ma'am.
The third question will be discussed. Dr. Monia Jaman is not here, right? Okay. Dr. Umesh Shahajat, third question.
Yes, ma'am.
Yeah.
Pregnant in 38-week gestation age with polyhydramnios and premature rupture of membrane recently. Presented with painful vaginal bleeding and uterine tenderness. CTG findings shows persistent fetal bradycardia. What would be the cause? Cord prolapse, abruptio placenta, vasa previa, and option D is placenta previa. It's ma'am option.
Yeah, Dr. Omar, you
Option
will
A,
tell me these
cord
are the
prolapse.
point, and these I am thinking. See, there is a 38-week gestation, right? Polyhydramnios, right? Prom. And this one. What is that?
It's option A, cord prolapse.
No. So see, prom and painful vaginal bleeding. Okay. Painful vaginal bleeding. So you can see it's a cord prolapse due to bradycardia, right? You are thinking, ma'am, it's a bradycardia, it's a cord prolapse. Yes. Your answer is correct if they ask what could be the cause. The cause for the bradycardia is a cord prolapse, the painful. So there's two answer. What is that, Dr. Umer? Two answer. First of for the painful, another for the bradycardia. So for the painful
Ma'am, it's
vaginal bleeding,
option D, placenta previa, low-lying placenta.
painful for what? Painful. Previa always painless, right? PP. I also discussed PP for also previa is the painless. For painful for the Vasa previa painless, and the placenta previa painless,
It's
cord prolapse
option B,
bradycardia.
placenta abruption.
Option B. Yeah, option B. Dr. Omer, just strongly remember from today, in exam, just give a menu. Means PP, painless bleeding is a previa, all are pre. Painful PA is a abruption, it's a painful PA. Just remember. These are the menomes. Even in exam, same scenario you will face, and you have to answer this way. Painful means abruptio. But you confused by this way. In exam, if same scenario they give, their explanation they given by abruptio, but in my side, this are the recall, MOS exam recall. In my side, cord prolapse due to the bradycardia, but this painful due to the abruptio. Here, high yield point, this bradycardia complication of the abruptio. So I have to mark first abruptio placenta, which causing bradycardia. Clear?
Yes, ma'am.
Okay, clear? Don't forget it.
Yes, ma'am.
Same scenario I discussed with other candidates that painless bleeding, but bradycardia, it was the placenta previa. Sorry, it was a vasa previa. So vasa previa, it was painless, but Shamim Shahid, yes, maybe I will discuss. Vasa
Yes,
previa.
ma'am. Ma'am, just I want to ask one thing, that the fetal bradycardia can be a feature of vasa previa. So we can only differentiate on the painful vaginal bleeding because vasa
Yeah,
previa is a painless.
painless. Yes, yes.
Okay, okay, ma'am.
I was discussing this. Just your question, your explanation. I am discussing Dr. Umar because this is the clinical exam scenario. Dr. Umar, just see, if it is painful, I have to mark abruptio. If it is painless, it's a vasa previa. But if there is a bradycardia, but if there is no bradycardia, only painful is clinical scenario, it's a abruptio. If there is a CTG image, CTG interpretation, if they give the CTG picture and corporal of CTG picture, I'll discuss today. CTG picture I'll discuss today. How, when I have to mark corporals, I'll discuss later bit. Okay, Dr. Umar, clear?
Okay, ma'am. Thank you.
Okay. Just give me 1 minute. So, my dear candidates, see placenta previa, painful vaginal bleeding. So, see the explanation Dr. Umar case. Painful vaginal bleeding, uterine tenderness, placenta abruptio. Also, polyhydramnios, especially after rapid decompensation, is a risk factor for placenta abruptio. Listen very carefully. Previa painless. Cord prolapse will not present. See, Dr. Umar, cord prolapse will not present with bleeding and tenderness. Dr. Umar, clear? Cord prolapse never present with bleeding and tenderness. It is excluded. Only
Okay.
present in hospital with CTG bradycardia. Clear?
Yes, ma'am.
So there is a chart. I hope it will be more clear when if though they're in screen maybe it's unclear. Just give me 1 minute, doctors, just for interpretation. Okay. So first question will be discussed with me my I said Dr. Priya is here. Today Priya is okay. Priya's health was not good as per informed. Okay, Dr. Kishori, first question. Are you here, Dr. Kishori?
Okay. Yeah, I'm here.
Ma'am, I'm there.
A 30-year woman, gravida 2 para 1 at 34 weeks plus 2 days of gestation, presents to emergency room reporting painless vaginal bleeding. Painless vaginal bleeding. Immediately, TVS shows placenta completely overlying the cervical os. Placenta completely overlying the cervical os. A fetus in cephalic presentation, and an amniotic fluid index is 14. The is very high. The cervical appears long and closed on speculum examination. She has slow, continuous vaginal bleeding. Fetal heart is monitored. BP is 110 by 78. Heart rate is 106. Respiratory rate is 14. Temperature is 36. Now, which of the following is the most appropriate in management? Hospitalization, betamethasone, cesarean section, magnesium sulfate. She has painless vaginal bleeding and she is 34 plus 2 weeks of gestation. And in the TVS, it shows placenta completely overlying the cervical os. And I think if placenta is completely overlying the cervical os, she need to hospitalize, ma'am, or hospitalization. Because this is a high risk patient.
Here, main point is a high risk patient. Yeah, excellent. Excellent.
Yeah.
It's a high risk patient, so we have to do hospitalization. Clear? Thank you. Its main point you understand very nicely, Dr. Kishori. I already appreciated that. Here, main point ultrasound showed placenta completely overlying the cervical os. Okay, so it means it is transversely present. So it's a high risk case for the further ongoing pregnancy. So it's a even patient, it's a mom even stable. We have to do follow up. We have to keep monitoring for the further progression of the pregnancy. Clear, doctor?
Okay, ma'am.
Yeah. So this question will be Dr. Priya was telling she is here. Dr. Priya, I hope you are here.
Ma'am, I'm there, ma'am.
Yeah.
Good evening, ma'am. 34 weeks gestation age presenting with heavy bleeding and contraction. No pain mentioned. Ultrasound showing fundal posterior placental with retroplacental fluid and baby in transverse lie. 3 centimeter cervical dilatation. What to do? Option is cesarean section, B observation, C tocolytics, D extracephalic version. Since there is heavy bleeding and transverse lie, you have to do cesarean section, ma'am. Option A.
Yeah, excellent. It's the option A, cause why? First point here, ultrasound picture. Posterior placenta
Yes.
with retroplacental fluid and baby's
Fluid
transverse
and
lie.
baby in transverse lie.
Even
Yes,
same
ma'am.
question. Yeah, even same question was my recall. Same question they posted this way, retroplacental fluid and baby in transverse lie. So we have to do cesarean section. Okay, thank you, doctor.
Yes.
How is
Thank
your
you,
health? Are you okay right now?
I'm better now, ma'am. Good, ma'am. Thank you, ma'am.
Soon you will be okay. So this first question explanation that Dr. Kishor's question, there's some explanation. So the hospitality, the mother is vitally stable. Okay, Dr. Kishori case, mother is vitally stable. So the first question was that their mom, there is no vitally instability. BP was right, heart rate was right, temperature was right, and she has slow bleeding, but not significant or heavy. I have to do resuscitate and monitor the fetus. So active bleeding if present, if previous, it is obstetric emergency. If there's a bleeding, it is an obstetric emergency. Okay. So Dr. Kishori's case, gestation was 36 weeks. Okay. Here, betamethasone at 34 weeks, cesarean section, and magnesium sulfate. The explanation I have to assess by how? First of all, if active bleeding is the obstetric emergency, if labor and delivery unit for maternal and fetal monitoring and the anesthesia team should be there, our goal of management is the bleeding maintaining. So achieve and minimal maternal hemodynamic stability. We have the placenta previa. If there is achieve or maintain maternal hemodynamic stability, determine if emergency cesarean birth is indicated or not. So for our case, cesarean section is indicated if significant vaginal bleeding after 34 weeks. Dr. Kishori's case was 34 plus 2 weeks and mild bleeding. So only here we have to do hospitalization cause amniotic fluid index 14, there is a painless vaginal bleeding, it's an obstetric emergency, we have to do hospitalization. If it is only 34 weeks or below 34 weeks, betamethasone I can give after admitting the patient. Cesarean section I have to do if it is more than 34 weeks right now, because still there is no heavy bleeding, I can admit right now, I can wait, but there is a chance of heavy bleeding, we have to do cesarean section. But mild bleeding category, so see, we have to do no stress test. Okay. Fetal heart pressing you have to do. If it is below 32 weeks, you have to do magnesium sulfate to prevent further complication. So three way this question asks, what is your management? If there is a cesarean section option management, I have to make cesarean section cause bleeding started, os closed, and there is a management is cesarean section. But the options another way they ask, hospitalization, betamethasone, cesarean section, magnesium sulfate. So most appropriate in this case is not cesarean section cause why? It's a not heavy bleeding. It's a mild bleeding and it's not so emergency. So two way I can hospitalize, I can monitor the fetal heart rate, and then if needed, there's a multidisciplinary team. I have to call tertiary level hospital doctors. So we have to do cesarean section later. Okay, but if the directly given heavy bleeding, I have to mark cesarean section, whatever the background information. I hope all clear this question. So labor and CTG monitoring today, actually from myself I always make easier. So there is a variability, acceleration, deceleration. I'll discuss those topics. Shortly regarding the CTG interpretation, see, early deceleration means this happen due to fetal head compression. So question early deceleration due to fetal head compression. As the fetal head is passing through the pelvis, deep of fetal heart rate coincide with maternal uterine contraction. So see, these are the contraction and these are the fetal heart rate. So these are the coincide. So if I say in ECG, I always this combined with ECG because why? In ECG there is a PQRS and there is again PQRS. So this is a sinus rhythm. There is no P wave absent. There is no RR interval irregular. This is the regular heart rate. So regular heart rate means normal. P wave, QRS wave, again P wave, QRS. Now there's no complete heart block, there's no variability, there's no irregularity. So this is the common, this is the normal. So acceleration, early deceleration. So early deceleration means fetal head is passing. Okay. It is reassuring. We can do reassure the mother and early deceleration head compression exam question. Early deceleration means what? It's the head compression, it meaning. So when there is sinus rhythm or complete normal rhythm, there's each contraction fetal are passing through the pelvis, it's a normal. So I have to reassure the mother there is no intervention needed. There is no needed early induction of the labor, no needed for the cesarean section. So see, these are the important sorry for the net was disturbed. So see the contraction, as I said, there is a each contraction fetal heartbeat or fetal head are downing nicely. There is a each contraction and there is a nature of the coming through the each active labor. So these are the, if I say the sinus tachycardia or sinus rhythm in ECG, so these are the early deceleration reassuring the mother. Okay. Now late deceleration. So late deceleration, see, candidates are leaving or entering. So late deceleration means what? See, it's a placental insufficiency. My MOH candidates, very important placental insufficiency, they give direct. So placental insufficiency is a pathological deep in the fetal heart rate does not coincide with each contraction. So placental insufficiency, my another name is irregularity or atrial fibrillation, is my manomics. So see, there is a contraction but fetal heart rate is there. There is a fetal heart rate. So irregular. Variability, placental variability same way, but late deceleration means each contraction fetal heart rate goes later. Okay, so it's a pathological fetal heart rate not coincide with each contraction. It's a late deceleration associated with placental insufficiency. So see this late deceleration picture. I say another name is a bradycardia. In exam, you see this picture. If you remember my word bradycardia, irregular bradycardia is enough. It's a late deceleration. So I said atrial fibrillation because this is not coinciding. Another said it's a bradycardia. It's not coinciding, but in atrial fibrillation, actually as I'm working cardiology, in atrial fibrillation, it could be the tachycardia, it could be the bradycardia, but it's not coinciding each contraction, so it's a irregular. So it's a bradycardia in which is a late deceleration. Clear all candidates? Any question till now? Early deceleration and late deceleration. This picture we have to face in the exam. So late deceleration question associated with placental pathology, placental insufficiency, post-maturity, hypertension, diabetes, placental abruptio, excessive uterine contraction, incidence of the injudicious use of the oxytocin, and there is a regional anesthesia or epidural anesthesia associated with late deceleration. Okay. Now, variable deceleration, another what? Another atrial fibrillation. It's my word. It's another irregularity. So variable deceleration is once that fetal heart rate dip can be before the peak uterine contraction. Can be before peak uterine contraction. So this is the uterine contraction, but before there is a fetal heart rate. So means starting contraction, but fetal heart rate is still not started. So before. So before when this fetal heart rate started, is a variable. So it's a variable in nature. So uterine contraction is not again coincide or not correlated with fetal heart rate. So my manomis is that late deceleration remembered by bradycardia and variable deceleration remembered by atrial fibrillation. That fetal heart rate is not coincide, is before each contraction. Okay, so see, these are the images. These are the fetal, this is the uterine contraction, and these are the before that fetal heart rate. This is not coincide with each. There's nothing. This is a, you can say, is a no consequences each contraction and heart rate. Another picture this way, in exam picture, this will be the exam picture, is the variable deceleration. Sinusoidal pattern already discussed. This is stable baseline fetal heart rate, but fetal anemia, fetal-maternal hemorrhage, fetal hypoxia associated with sinusoidal pattern. It's my manomesis that it's a supraventricular tachycardia or it's a tachycardia. Ventricular tachycardia is ongoing. It's my manomis actually. So it's a sinusoidal pattern associated with hypoxia. I hope all clear. Any question from anyone from CTG interpretation, ask me, because there will be lots of questions for practice. Okay, all clear, excellent. So see, these are the picture. Bradycardia, fetal bradycardia below 110 and fetal tachycardia more than 160. So see, there is fetal bradycardia and tachycardia, the minimal variability, the picture, and moderate variability picture, and there is acceleration picture. Okay, the variability you see, I say this is the atrial fibrillation. There is no fetal heart rate coincide with the each contraction. For the late, you see the bradycardia in nature. Okay, in early, before each contraction, each fetal heart rate is a normal and reassuring episodes. Okay, same way, this is the category 1. In CTG, there is a category 1, category 2, and category 3. CTG category 1 means there is a maternal fetal heart rate variability, but it's reassuring. Early deceleration. In CTG2 indicate fetal heart rate tracing is not reassuring. It's a, we need further evaluation. Okay, and CTG3 we have to further deteriorating the mom's condition, fetal distress. We have to do cesarean section. Now stages of labor. First stages of labor. So see, latent phase. In first stages of labor, there will be the active phase, there will be the latent phase. In active phase, after the latent phase. So in latent phase means what? Onset of labor and 6 centimeter cervical dilatation. So when started the labor, but when cervix fully dilated till 6 centimeter, it is latent phase. But active phase means what? Latent is when more than 6 centimeter and cervical dilatation and end with complete dilatation is the active phase. Means what? When 6 centimeter till that is a latent, but active means what? It is more than 6, like 7, 8, and cervical is fully dilated. Complete dilatation is the active phase. Secondary stage of the labor means cervix completely dilated end with birth of the infant. It's a second stage. Third stage means in birth of the infant and complete expulsion of the placenta. So first, second, and third stage. So when placenta fully expelled from the uterus, it is third stage. Till infant delivery is the second stage. So abnormal labor, there will be the prolonged stage of the labor. So first stage of the labor, prolonged means is more than 20 hour or 18 hour. If it is cervical dilatation below 6 centimeter, it is prolonged stage of the labor. So management, we have to give supportive management. Unless PROM means what? If there is no premature rupture of membrane, we can give supportive management. Prolonged stages of labor, but still not ongoing, we have to do augmentation of the labor by oxytocin. Prolonged active phase. Prolonged active phase means what? Cervix more than 6 centimeter dilated, along with, when I said it's prolonged but active, but cervix dilated 6 centimeter, 7 centimeter, but inadequate contraction. Uterine contraction is not adequate. Same way, uterine contraction is not adequate within 4 hours. So these are the definition for the prolonged active stage. We have to manage by oxytocin in prolonged active phase. If arrested or inactive means 6 centimeter dilated or 8 centimeter dilated, there is no contraction. Inactive phase or arrest active phase means a stop. If active phase, we can do induct the labor. Remember very well, we have to do cervical ripening. Okay. If arrest means stop, when I will tell this, there is no contraction. So we have to manage by cesarean section. In arrest, prolonged active phase. My dear candidates, listen very carefully. Prolonged active phase or prolonged labor, but not active phase. Active phase means uterine contraction there, but inadequate or irregular or incomplete. But 6 centimeter dilatation, more than 6 centimeter dilatation, we have to do augment or we can do induct the labor. But there is a labor 18 hour or 16 hour. We have to do, but there is no contraction, then cesarean section is the choice of the option. So first question will be discussed with me, Dr. Maha Umer. First question.
Yes, ma'am. Primary gravida during labor. Cervix fully dilated. CTG show variable. Question is not clear on my screen. CTG show variable declaration. Patient has strong contraction and head is engaged. Station 0. Cephalic presenting part. What is the most appropriate management? A ventouse, B forceps, C C-section, D wait for R. Cervix is fully dilated, CTG show variable deceleration, strong contraction, head is engaged. Cephalic band, option A, ventouse. Vacuum.
Why ventouse? First of all, you see variable deceleration, but strong contraction, but strong
Yes,
as cervix fully dilated.
Yes, ma'am.
When
And head
cervix
is
fully
engaged.
dilated, when cervix fully dilated, okay. What about the
Yes,
waiting?
Ma'am, patient head is engaged, station 0, cephalic presenting
But
part.
station, yeah, but station 0. When we do in ventouse, if station +2, +2.
Yes,
But here, station must
station
indication
0.
for ventouse if it is +2, but 0 means very higher position.
Yes,
very
ma'am.
higher position. So we have to do wait.
Wait for 2 hours.
Yeah. Okay, clear? Very important exam question. Clear? When station +2, we have to do ventouse. Neither. We have to do wait cause there is a contraction good and CTG variable and this service fully dilated. 3 points. Service dilated, contraction good and station 0, but we can do wait and cephalic presentation. Okay.
Yes, ma'am.
Second question. Okay, thank you, dear. I'll discuss later. So second question will be discussed with me, Dr. Dr. Nipuni is able to talk with me? If Dr. Nipuni not here, no issue. Again, my cycle from my first candidate. So first question, second question will be discussed with me, Dr. Donilda. Second question, this one.
Yeah,
Which
ma'am.
CTG? Yeah.
Pregnant on epidural and oxytocin suddenly contraction stopped. CTG picture as shown above. What would you do? It is the stop oxytocin and immediate delivery, stop epidural, increase oxytocin, change to lateral position and recheck after 20 minutes. I think it's a late deceleration. So stop oxytocin and immediate delivery.
Okay, excellent. It's a stop oxytocin and immediate delivery. So first of all, it is the complication of having oxytocin. It's an oxytocin side effect.
Oxytocin. Yeah.
Okay,
Yeah, right.
so we have to do.
Yeah.
It's actually the CTG picture is not late. It's a variable. So see the
Variable.
it's
Huh.
I said it's atrial fibrillation. It's my actually it's my language. So it's a variable. So we have to do immediate delivery. Stop the oxytocin. Okay.
Yeah. Okay.
Clear?
Yeah. Okay.
Okay.
Thank you.
Okay.
Yeah. Yeah.
Yeah.
Thank you.
So this question will be discussed. This one. This one will be discussed with me. Dr. Reza Uruzi is here.
Yes, ma'am. A primary gravid patient presented in labor, and the cervix is 5 centimeter dilated, and the fetus is in a station 0 with cephalic presentation parts, and is stayed for 4 hours. Then oxytocin has been taken. CTG picture as shown above. What is the management for this patient? Late deceleration. CTG shows late deceleration, and also cervix is 5 centimeter, fetus in station 0. Stop oxytocin, immediate CS, wait for 2 hours, instrumental delivery. Option D and E excluded because it's an emergency, because CTG late deceleration means and that gestation, the cord is not transfer enough blood, and it must be a stop, first stop oxytocin, and the best treatment is immediate CS. I think option C.
Dr. Reza, give me 1 minute. I'm discussing.
Okay.
Sorry, doctor. So first of all, Dr. Reza, so you said your management will be the first stop oxytocin, right?
Yeah, yes, but the best management is immediate CS.
Yes, yes.
Immediate,
But
yes.
yes, it is the answer is the immediate CS. So you have to do
Yes.
immediate CS right now, okay? Because
Yes.
5
Yes.
centimeter dilated, encephalic presentation, and 4 hours. Already
Yes.
your patient is on oxytocin, but there's no progression already. There's a variable distillation. So see, there's a variable distillation picture. So you have to do immediate CS. Okay,
CS. Yes.
clear?
Thank you.
Okay, yeah. Now last question will be discussed with me, doctor. Yes, Dr. Umer Shahajat. This one.
Yes, ma'am. A
Yeah.
39-week pregnant patient, history of cesarean section due to breech presentation. Now she is in labor with regular contractions for every 5 minutes. Cervix fully dilated, full effacement, station +3. What is your management? Venous delivery, cesarean section. Examine her after 2 hours.
So Dr. Umer, your point here, see, what are the points? First of all, breech presentation, right?
Yes, ma'am. History of previous C-section and
Previous,
breech
yeah. It's a
presentation is
previous
there.
history. It's not now. It's not now.
So
It's a
it's
previous history.
option B, cesarean section.
No, no. That is the point I'm telling. It's a 39-week, but history of cesarean section due to breech is a previous history. But now your patient, you are a doctor, contraction regular, service fully dilated, but presentation they didn't give means what? Presentation they didn't give means cephalic presentation, indirect question. That's why I'm discussing. Contraction ongoing. I have no doubt, or I have no emergency regarding the contraction cause this is a cephalic presentation. But before it was cesarean, in which we done for the breech presentation. But now contraction good, cervical dilatation fully, and full effacement. See, full effacement means what? Head fully engaged, Dr. Umer. See,
Yes,
fully
ma'am.
engaged, and station is +3. Station is +3 means what? It's a good, very good. Okay, it's a very good. Okay, doctor. So right now, it's a ongoing progression. So if you say B option is correct or not? B. It's a cesarean
Ma'am,
section is
as
not
there,
accepted.
and she has a history of previous C-sections. Oh,
Yeah. But now patient contraction good, effacement good, dilatation good, all good. This is the twisting question. That's why I'm discussing with you, because this is the actual MS question. They confused you by given cesarean section, but if anyone have a one cesarean section history, but she can do a normal delivery even after that. Okay, it's not a contraindication for doing normal delivery. Okay, but our headache is that first is cesarean section, so second will be also cesarean section. No, but it is not. Okay, so second, so now what you will do, doctor? So second, what you will do, doctor?
it's option A, venous delivery.
Yeah, it's a venous delivery. You already get the point. It's a venous delivery. So why? Cause all are good. I said venous we do if station +2, right? Here
Yes, ma'am.
station +3 is a very good. So we have to do venous delivery. Okay. But don't be confused by previous history, cesarean section, previous whatever thing. Fully effacement means there is a head, fully dilated cervix, station +3. So we have to do venous delivery. Clear, doctor?
Yes, ma'am. Yes,
Any
ma'am.
confusion in this question? Any confusion? This were most trickle. Yeah, ask me. What are the question? I can't hear your voice. Unfortunately, just raise your voice.
Fine. We
Yeah,
will
yeah.
not do this section because of previous history of cesarean due to breech presentation. But now, ma'am, why we do ventouse delivery? Because the effacement is good, the station is positive 3 and contraction is 4 to 5 centimeter. Everything will be fine with the normal delivery. So why we use ventouse? Because ventouse delivery is done when there is need of force or poor progression.
Hello? Hello? Is that my voice is clear?
Yes, ma'am, now clear.
Yes, ma'am.
Yeah, what
Yes.
is it? Yeah, Dr. Saba, what was your question?
Ma'am, my question was that why we use the option A, ventouse delivery, because ventouse delivery is forceful um, pumping of the boy or anything fetus, because there is everything is good for contraction 4 to 5, cervix fully dilated, full effacement, and station is also positive 3. So why we not go for this option 3, examine after 2 hours?
No, why not? Yes, it is the point. First of all, why not examine her after 2 hours? First of all, you see, patient already fully cervix dilated, full effacement done. So, if we wait, also it will increase rupture of the uterus, cause I can't do wait because already all effacement done, dilatation done. We have to do as soon as possible, deliver the baby, whatever the ventouse or forceps. But we don't use forceps commonly. We use ventouse is a very suitable. It will not injure the baby's head. So right now, the pressure even it cause, but it will helpful for the mother for further complication by waiting. And even if we do the ventouse, it will be good for both. Clear? If we do wait, it will be harmful for the mother because ongoing contraction, Dr. Saba. If it is ongoing contraction, if we wait, it will be harmful for the mother. It will cause rupture of the uterus. Okay, clear?
Okay. Yes, ma'am, clear.
Yeah.
Thank you, ma'am.
So yeah, thank you. But this question I want to discuss shortly. Ventouse delivery CTG category 2. First of all, I want to discuss regarding the CTG category 1, 2, 3. CTG category 2 and 3, just shortly remember, my dear candidate, then I will explain details. CTG category 1 mean is normal, is strongly indicative, fetal heart rate normal. Okay, so there's nothing to be worried. But CTG category 2 means bradycardia, variability, tachycardia. It's the CTG category 2. Minimal variability, these are the CTG category 2. Marked variability. But in CTG category 3, in 3, absent baseline variability plus recurrent late deceleration, recurrent variable deceleration. These are the 3. These are the CTG 1, 2, 3. Why I'm discussing this one? First of all, CTG category 2, in this ventouse delivery, Dr. Umer case, in Umer case, contraction coming, cervix fully dilated, this presentation was history, but not now. So, in this case, if CTG category 3, immediate CS means variability. If CTG category 1, we can wait for 2 hours. But here, there is not CTG category 1. Here, all are normal except contraindication is previous history of the cesarean section. So, we have to manage by ventouse delivery. Okay. CTG category very important is 2, managed by resuscitation. If it is 2, we have to do lateral position. 2 means what? 2 means variability tachycardia. So first we have to do lateral position of the mother, then IV fluid, stop oxytocin. This is the management. They say details. In CTG category 2, what we do, CTG category 1. So see, in 1, we can do weight. Dr. Sabas case, ma'am, why can't we do weight? We can do weight. But I said here, history of the previous cesarean section, I can't do weight. It will increase contraction cause rupture uterus because there is a history of a scar previously. But if there is no, if same question, DHA question actually, if there's nothing, CTG category 1, normal fetal heart rate, normal contraction, cervical dilatation, so we have to wait till 2 hours. Clear? Any question? 1, 2, 3, if when contraindication, when indication? Any question? Or clear? Any question from anyone? Okay. Stop oxytocin immediate delivery. I will discuss this question from, I forget the name of the candidates. Just remember, we have to stop the oxytocin when CTG show variable deceleration. Okay. This one is this oxytocin side effect. So there's a lots of question I'll discuss today because it would be, if we discuss, it will be more clear. Neither all will got mismatched in exam. So first question by Dr. Kishori. First question.
Okay. Pregnant patient in labor. On examination, cervix is fully dilated for 2 hours. Cervix is fully dilated for 2 hours. Head in a station -2. Head is -8 in -2 station, but the patient is good, exhausted from pushing. What is your next step? CS delivery, wait for another 2 hours, ventis delivery, forced delivery. Season labor, station is -2. Though the cervix is fully dilated, but patient got exhausted. So we can't wait for 2 hours. Ventus delivery, if the station is +2, then we can go for ventus delivery. So it's not possible. Forced delivery also not possible. Ma'am, it's CS delivery.
It's the CS
It is,
delivery. Because why?
yes, ma'am.
Because it's the -2 station, very higher, but fully dilated, but it is no contraction. It's exhausted, patient exhausted and pushing. So we have to
Yes,
do
ma'am.
CS delivery. Thank you, doctor. Very done. Excellent done. Second question will be done by Dr. Badhun is here. Second question.
Yes, ma'am.
Yeah.
Pregnant female, primary gravida in labor for a couple of hours. 6 centimeter dilated, 80% effacement, station 0 was managed with oxytocin and ruptured membrane for 20 hours. CTG showed late deceleration. What is the appropriate management? Okay, CS, stop oxytocin, amnio infusion, and ampicillin. Okay. What is the appropriate management? Late deceleration. Ma'am, appropriate management will be cesarean section, as it's rupture membrane for 20 hours, and after good effacement and full dilatation, CTG is late deceleration, so it's placental insufficiency. That's why we will choose cesarean section delivery.
Okay, clear? Yourself clear, right? It's the cesarean section we have to do. Excellent.
Yeah, thank you.
Okay. Third question. Third question is very important, but it's not so commonly asked, but I feel they ask from recent recall. Third question by Mehis.
Yes, ma'am. 20-year-old primary gravida, 42 weeks with closed cervix. Induction of labor with the prostaglandin gel was started. Her CTG was fetal heart rate 140 to 160. After 1 hour, fetal heart rate is 80 and uterine contraction lasts 2 minutes. Most important step in the management. 42 weeks with closed cervix. CTG was shows a fetal bradycardia. Variant 16 oxygen mask. Check code for that.
42 weeks, right?
Yes, ma'am.
42 weeks and closed cervix.
Ma'am,
And
cesarean?
CTG showing fetal heart rate higher.
Yes, ma'am.
Answer what?
Ma'am, fetal heart rate is higher, but after 1 hour, fetal heart rate is 80. And
Yeah,
uterine
excellent.
contraction lasts 2 minutes. Most important step in the management is, ma'am, cesarean section.
Yeah, this is actually not a direct question, doctor. First of all, last 2 minutes uterine contraction. So within 1 hour, fetal heart rate drop and uterine contraction also become dropped. Both dropped. Okay. Only 2 minutes one contraction like that or no contraction. So most important step we have to give uterine tocolytic agent or tachycystol agent. So what is the answer?
And C.
Answer is yes. Answer is subcutaneous terbutaline. Cause to increase contraction, right?
Okay.
Increase 5 contraction in 10 minutes. So if every 2 minutes I need more than 1 contraction. So the average over 30 minutes would be the uterine hypersystole or hypertonus. So we have to give uterine tachycystole, discontinue oxytocin. We have to give uterine tachycystole, and it's the subcutaneous. It is subcutaneous terbutaline. Clear? Or any question? The question got you may confused by after 1 hour fetal heart rate 80 and uterine contraction lasts 2 minutes. So 1 means within 2 minutes no contraction. I feel there is a noise. So if no contraction within 2 minutes, it's not appropriate. I need contraction each. I need contraction and heart rate with each contraction. So I have to give subcutaneous terbutaline. Okay, to improve the hypotonus and contraction lasting at least 2 minutes. So uterine tachycystole, one of the cause for fetal bradycardia. So tachycystole managed by discontinue oxytocin cervical rapine administer tocolytic terbutaline. We have to check even cord prolapse or rupture of the membrane. So see, uterine tachycystole, if more than 5 contraction in 10 minutes, average over minute window. So we have to remember that it only also cause for the bradycardia. So we have to give tocolytic agent. First question by Dr. Shruti. First one, this one.
Pregnant lady, 41, gestation age, in labor on epidural and analgesia. Admission surface for preeclampsia and oxytocin. CTV showed prolonged deceleration and the mother was hypotensive. Most likely caused the CTG findings. Patient is in labor on epidural and also on admission surface of preeclampsia and oxytocin. CTG is showing prolonged deceleration. Mother was hypotensive. With oxytocin.
Most likely cause of the CTG finding. First of all, epidural analgesia, Dr. Shruti. These are the culprit for having what? For having prolonged deceleration. And mom become hypotensive. I will discuss in detail later, okay? So its answer is the epidural analgesia for causes this CTG finding. Prolonged deceleration. Okay. Direct question, exam question. Second question by Dr. It's a Hira. Dr. Hira is here. If Dr. Hira not here, Dr. Ikra.
Yes, ma'am.
Pregnant 38 weeks, diagnosed with preeclampsia and managed with magnesium sulfate. She is in labor and epidural anesthesia was started. Oxytocin infusion is started as well. Normal regular contractions. CTG picture as shown above. What's the cause of this CTG finding? Oxytocin infusion, magnesium sulfate infusion, epidural anesthesia, and head of position. Ma'am, I think it's magnesium sulfate infusion.
Excellent. What are the point in favor?
Ma'am, because it shows the reduced variability in the CTG.
Okay, excellent. So it's a magnesium sulfate infusion. You done very well. Thank you, doctor. 2, question 3 and 5. Both questions will be discussed by Dr. Kishori. Both 3 and 4.
Question 3. Okay. 35-year-old pregnant lady with fetal death and DIC. Her cervix is 4 centimeter dilated. Her vital shows hypertension. What is the management? She is 35. Okay. Fetal death and DIC. 4 centimeter dilated. In DIC patient, IUL is not possible. Normal vaginal delivery is also not possible. Ma'am, we go for CS, urgent CS, ma'am.
What are the point? You are choosing urgent CS first?
Ma'am, first is fetal death. And there is DIC. And though the cervix is 4 centimeter, as we count this for active labor, but the DIC, the indication is cesarean delivery. And mom, maybe the mom is or vitals unstable, hypertensive.
It's not unstable, it's an unstable situation. Okay, now second question. Same, but second question.
Pregnant with DIC and CTG normal, no deceleration and good contract, what to do? Pregnant with DIC and CTG normal, CTG is showing normal, no deceleration, good contraction, augment labor and DIC augment labor normal. It's not possible. CS DIC could be possible. Reassure, we can't reassure. Ma'am, it's B.
Okay, that's what I'm discussing. Here DIC but CTG normal, good contraction. Okay, and if we do CS, it will increase bleeding capability. Because all normal. Even they didn't give any vitally unstable sign. They didn't give for CS. So here we can do what?
Oh, we can't do CS, but we can reassure, ma'am. I don't know.
Right now, that is the point. That's why I'm discussing with you.
Okay.
I feel this question is very important because DIC patient hemodynamically stable, and now we have to do induction of the labor. Okay, all
Okay,
normal, all normal. But if same question, if vital unstable, every point is very important. If unstable, we have to do CS. If stable, we have to do induction of the labor. Cause if CS we do, it will increase bleeding and life-threatening condition of the mother. So both important. Vitally stable or unstable. Stable means we can do induction of the labor. Okay.
Okay, ma'am.
Clear? Any question? I am reading this explanation. Thank you, doctor. Hemodynamically unstable mother, unstable fetal distress, contraindication to vaginal delivery. Cesarean delivery is indicated. Mother hemodynamically unstable, vaginal delivery we can't do in this instability. But if it's stable, we have to do induction of the labor because cesarean delivery because of the risk of uncontrolled bleeding from surgical incision and laceration. Clear? Any question? If we do CS, it will increase bleeding from the laceration site. Clear?
Yes, ma'am.
Okay. So 2 questions I'll discuss right now. First question will be discussed with me, Dr. Maha Umer.
Yes, ma'am. Pregnant Gravida 3 para 237 weeks with history of C-section because of non-reassuring CTG. She is in labor with a 4 centimeter dilation. The presentation is breech. What is the absolute contraindication of external cephalic variant? History of C-section, B, active labor, C, variable deceleration. Absolute contraindication, ma'am. A option, history of C-section. Hey, ma'am, absolute contraindication of variable declaration, option C.
Yes, yes, yes. Don't be confused. Okay. Answer is C. Okay.
Absolute C,
Thank
ma'am.
you.
Yes, ma'am.
So absolute and contraindication and relative contraindication I posted here. Just remember this way. Thank you, doctor. Further two question I'll discuss later. So preterm labor, pre-labor rupture from and preterm rupture of the membrane. So remember, this is just shortly I'll discuss this topic. Regular uterine contraction with cervical effacement, dilatation, and both before 37 week gestation is a preterm labor. Contraction there, effacement there, dilatation there, but before 37, so it's a preterm labor. Management, if more than 34 weeks, we have to do delivery immediately for admission and we have to do delivery. But if it's below 34 weeks, we have to give betamethasone because a single course of corticosteroid is recommended for pregnancy between 24 to 34 weeks of gestation who are risk of delivery within 7 days. A single repeat course of corticosteroid given consider who are less than 34 weeks. Okay. Tocolytic we can give within 48 hours and magnesium sulfate if gestation 24 to 32 weeks. So the management, we have to do the speculum examination. We have to do induction of the labor. Expectant management, we have to give the Guillain-Barré prophylaxis to prevent the infection by giving amoxicillin. Okay, so Guillain-Barré prophylaxis, the Guillain-Barré syndrome prophylaxis, tocolytic drug we have to give, and preterm labor to prevent, we have to give magnesium sulfate. Okay, and we have to assess the uterine contraction, uterine infection, abruptio placenta. Okay, non-reassuring fetal testing. So we have to do this. So this way, remember, my dear candidates, premature rupture of membrane, we have to do speculum examination. We have to do induction of the labor if it is 12 to 24 hour reasonable contraction, and if there is no infection, we have to do expectant management. So premature rupture of membrane, if it is below 37 weeks, we have to see either we can do immediate delivery or not, and according to the prophylaxis and tocolysis agent. Any question till now? Anyone have any doubt, any confusion? Today my labor session of the gynecology is not so easy. Regarding the CTG interpretation, variable distillation, late distillation, and early distillation, 3 part, and sinusoidal pattern still not posted, but in sometimes in hard exam they given. And the management, I'll post the PDF. Sometimes I saw that in my Zoom there is some blurring, so it will be posted nicely in the PDF form. Then you can read by opening the PDF and my session, and it will be more nice to understand the clearly. So I hope my session ended today, and all my candidates doing practice, alhamdulillah, all are passing, alhamdulillah for that. If anyone have any doubt, any confusion, must ask me. But after that, I may not be so active, but I will try my best to perform or any help if needed. So I'm ending my session today. Assalamu alaikum to all. Best wishes for all. Thank you, my dear candidates.
Thank you,
Thank you,
ma'am.
ma'am.
Thank you, ma'am.
Thank
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Yeah.